I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves. Let's talk today about ovarian hyperstimulation syndrome, or OHSS for short. This is something that I actually saw a ton of in the early part of my career. Like when I was actually a resident even, I did see some of it as a resident, but I did a lot more fertility specific stuff, obviously, as a fellow. I would say as a fellow, I probably rounded on a patient with OHSS about once a month. And like, I will tell you that my fellows today, like, I don't even know if they've seen a patient admitted with this because our treatments have gotten a lot better. Our prevention has gotten a lot better. And we now have something called Lupron trigger, which does almost eliminate all of the ovarian hyperstimulation syndrome. But I think if you're a woman physician who is on the fertility journey and you're barely able to make all of this work with, your clinics, your hospital duties, your rounding duties, you do your 2 weeks of ultrasounds and blood work and monitoring and then the retrieval. If you are then laid up with another 1 to 2 weeks of a complication like OHSS after that, and you feel like crap, you're third spacing. I've seen people even like their walk is now a shuffle. Sometimes people need anticoagulation or hospitalization or IR drains or, uh, basically an egg retrieval, but where you drain the cul-de-sac of fluid instead. That's really going to cramp your style as a physician. And it's also going to just add more morbidity and time and cost and frustration. And even like VTE risk is higher and miscarriage risk is higher. So I think this is a really important topic to think about because, what is your REI thinking about as they are preparing to do your IVF cycle? And what are some of the ways to mitigate the side effects of OHSS? OHSS is defined actually in terms of mild OHSS, which I will admittedly say that that's kind of the goal of all IVF is to at least get somebody to mild OHSS because we are hyperstimulating the ovaries, right? The whole point is instead of just ovulating one egg in a given month, that we capture the cohort. And in an ideal situation, you have at least a few follicles to work with. So, yes, we are trying to hyperstimulate the ovaries, but we're trying to avoid the ovarian hyperstimulation syndrome, which comes with, like I said, the third spacing and the discomfort and the additional risks. Moderate hyperstimulation, I mean, that can be defined by a lot of different criteria. One of them is ovarian size. Another is how much free fluid is in the abdomen. We often see free fluid in the abdomen even leading up to a cycle because the capillaries get a little bit leaky. And that's sort of part of my thought process in terms of the trigger decision, what to trigger somebody with to reduce the risk of OHSS. And also there's that question, if this person wants to have a fresh embryo transfer, is that a good idea? Because there's the first wave of OHSS, which is where somebody's ovaries are so vigorous and usually HCG trigger then, makes the vessels leaky and people can be nauseous and even have vomiting. And every now and again, you see even like mild LFT bumps and creatinine, nothing usually super dramatic, but to the point where, especially if you're in internal medicine and you're looking at the labs, you're like, oh shoot, this is a physiological alteration, right? It always gets better. It does. But it's one of those things where, yes, in fact, like OHSS does really affect the system. And so the first wave, if you think about the fact that the HCG trigger is out of your system in about a week, typically that's when people start to, turn the corner from their symptoms is like, a week after the trigger, which is about 5 days after the egg retrieval. The sort of abdominal bloating tends to get better. The ovaries start to shrink to their normal size. The third spacing starts to get better unless somebody is having an embryo transfer. And I will say some of the worst hyperstimulation I have ever seen has been in pregnant individuals because you really can't stop that train once it's started, right? So you get the first wave of the OHSS and then the embryo itself attaches and starts to make beta HCG. And then that then keeps the whole hormonal system going. So it's really that second wave of OHSS that is, the most morbid. But, like I said, even the first wave of OHSS can be super pesky and uncomfortable. if you're trying to get back to work, get back to baseline. A lot of times, if you're taking that time and blocking patients to get this done, sometimes pre and post, there's kind of like that, like almost like, when you go on vacation, before you leave for vacation, when you get back from vacation, there's like that clustering that happens on either side. So, the goal really is to sort of get people through this as smoothly as possible and what can be done to prevent and treat OHSS. So, moderate to severe OHSS is thought to complicate about 1% to 5% of IVF cycles. And like I said before, you can see ovarian enlargement, you can see ascites, you can see hemoconcentration. I've even seen like hematocrits over 50, hypercoagulability actually, and electrolyte imbalances. So it's really important to think about the fact that this really can affect physiology and trying to keep this. I always say safety and success must be balanced. And so it's trying to keep this as safe as possible. With mild OHSS, sometimes people just kind of feel like a little bit bloated. Maybe they gain a few pounds. They even say like, I feel like I'm pregnant, although I know I'm not. Like, sort of the body can kind of feel it. But with severe OHSS, especially if there's a lot of free fluid in the abdomen, it can push up on the diaphragm. People can have a hard time sleeping flat. It can really affect like taking a deep breath. People can have chest pain. They can have pleural effusions because again, all the third spacing of fluid. And VTE, I've seen people have need to be anticoagulated as well. Not even just lower extremity clots, also upper extremity clots can happen with this as well. So again, not to be taken lightly. Severe OHSS can really lead to some complications. But hopefully your REI can talk with you about that beforehand. What are some of the risk factors of people who are more likely to have OHSS? Certainly, if you're starting off with a high AMH, that's one of the most important things. I mean, more than 3.5 is usually when I start to think about somebody as increased risk, or maybe a high andro follicle count. If somebody's starting out with a AFC of 30 to 35 already, I usually use that data to kind of curb the medications. I might start them off a little bit lower than I might, if everything else was equal. And also just keep that in mind. I usually order a Lupron trigger ahead of time to make sure that I'm prepared. I will say where I work right now, I'm very, very, I'll use even the word blessed. I'm very blessed that the downstairs pharmacy just has it. So like it's never an issue. But in my other practices, it's sometimes an overnight shipment. If you don't think about it ahead of time and you realize on the day of trigger that somebody actually needs it, it can just be kind of a source of panic. Like, oh my gosh, we can't use HCG. She's going to get really sick. And oh my gosh, all we have is HCG. So I think the sort of the thinking about it ahead of time is a really important part of this picture. Women under the age of 35 are at increased risk of OHSS. It's actually 60% of OHSS cases are in women in that demographic. Low BMI is actually very controversial, but I will tell you some of my sickest patients have had a low BMI. And I think that probably it's because the HCG goes farther in terms of the volume of distribution. But anyway, that is controversial, but I would say based on my experience, I would say I do think about that in my risk algorithm. Somebody who has a diagnosis of PCOS is a lot more likely to have a diagnosis of OHSS down the line. People with tubal factor, because I kind of put that in a different category in my mind, or even unexplained infertility, and Black race also for reasons that we're not quite aware of. We're not quite sure why that is. In terms of ovarian reserve markers, like I said, high anti-Mullerian hormone, high andro follicle count, those are very good predictors for hyperstimulation. If you look at like the data, like AMH greater than 3.36, like, okay, fine. I said 3.5. The data would say andro follicle count over 24. I said like 30 to 35. Okay, fine. Just so you know the actual numbers of the studies that we look at. But you can just say like people who, if somebody has a andro follicle count of 4, I'm not really concerned that they're going to get OHSS. Also thinking about ovarian stimulation parameters, like how many follicles are there at the time of retrieval. Over 25 is a risk factor. Over 19 large or medium-sized follicles at the time of HCG trigger, that's definitely a risk factor. Over 24 oocytes retrieved is a risk factor, and also estrogen concentrations greater than 3,500. Although estrogen does seem to be one of the worst predictors, even though we all freak out about it, like, oh my gosh, her estrogen's 8,000. We can't give her HCG. It's usually because those other things are also present. And so just, one of my sickest patients with OHSS actually had an estrogen of 1,400. So, you just have to be very cautious not to just go on estrogen alone. We think about different stimulation protocols from the beginning. So I would say, like, over the course of my career, we are doing way more antagonist protocols compared to long Lupron protocols. But when I first started, we were doing a lot more long Lupron, in which you cannot use anything but HCG because your GnRH receptors are downregulated. And then, like, if you give Lupron, then nothing happens because the medication can't talk to the receptors. So, in a GnRH antagonist protocol, you actually have a Lupron trigger as a possibility, as long as somebody doesn't have like hypothalamic amenorrhea and they don't have any luteinizing hormone endogenously to work with. Like, usually you can use a Lupron trigger with pretty good results. But if somebody's on a long Lupron protocol or a microdose flare protocol, then you really do have to use an HCG trigger, just so you know. What are some preventative adjuncts? So some people have used baby aspirin. I know that's controversial. People ask if that increases the risk of bleeding. It's not thought to, but it does seem to have an effect on VEGF levels, and that's part of the pathogenesis of OHSS. If you use a dopamine agonist, actually, like starting from the point of trigger on, after the retrieval, there's good evidence that that can reduce the risk of OHSS. I love that. Give me a little bit of cabergoline, that's a really nice medication. Sometimes people have a few side effects like GI, like nausea or sometimes dizziness. So then you got to pay attention to that. But in general, that does seem to really do a good job in terms of reducing that third spacing. There's some data that people can actually use metformin, and that can really help in terms of their, OHSS prevention. Usually that's people with PCOS to begin with, but that medication in and of itself can have, some side effects. So I don't usually use that unless somebody has had like a history of bad OHSS and we're really trying to pull out all the stops. You can like start to decrease the dose of gonadotropins towards the end of the cycle. That's called coasting. Coasting is truly not giving any gonadotropins, but I kind of like a slow decrease at the end. And that can try to starve out the little follicles. That's sort of a philosophy. And then even like, I've used albumin usually in patients before, but you can use different like IV fluids and agents to help with that as well. Letrozole. So my personal cocktail, if I get to the point of trigger/egg retrieval and I really want to shut down the luteal phase, usually this is in people who are not planning a transfer, is I like 3 nights of antagonist, sort of after the retrieval. I like, several days of letrozole and several days of cabergoline, 8 days of cabergoline per the literature and 5 days of letrozole, but you can sort of make that a little bit more malleable to who is going to benefit in your practice. Or in sort of like just practical aspects. So I like that combination of things. It does not seem to have any harm. There's actually some data that it does shut down the luteal phase faster and reduce the symptoms of OHSS. So OHSS treatment, I think, if somebody has moderate OHSS, usually it's supportive care, usually trying to avoid, an embryo transfer. And if it's truly severe, I mean, sometimes we do manage this as an outpatient, but you really have to be cautious about ins and outs. Sometimes people need IV hydration, in which case, from my perspective, they really do need to be in a hospital. And also anticoagulation is important. I've worked at, different settings where sometimes paracentesis was preferred with IR. Sometimes coldocentesis was preferred, because we can do that in our IVF suite. But there's really only fair evidence for that. And because people need so much IV fluid repletion, and because, there's not a ton of evidence that that really does help people get back to baseline quicker, and it is fairly invasive, I usually only reserve that unless if somebody's having like short of breath or other, reasons why I really feel like their physiology is going to be better to do that, then I do. But, I just wanted to say not to be taken lightly. The whole point is, an ounce of prevention is worth a pound of cure, right? Or something like that. Anyway, so what I would say is the biggest thing is to identify who's at risk prior to stimulation, to choose a stimulation protocol that, is appropriate, to consider cabergoline and letrozole and antagonist as adjuncts, and to avoid a fresh transfer if there's a concern that, somebody really is at increased risk of OHSS from that second wave of HCG. There's also some things you can do to mitigate, sort of the side effects after the fact. In addition, like some people like cold packs, some people like heating packs. I think that sort of mobilizing, getting up and moving is helpful, both for mobilizing the third space fluid and also, VTE prevention. Those things can be very helpful as well. And also, is a common thread in a lot of my, content and in the way that I practice medicine is really give yourself some grace. Like if you're not feeling well and you still have an extra 10 pounds of fluid, from your IVF cycle, maybe you do call in. Maybe you do say you need a couple extra days to get back to baseline. And that's really not to be ignored. I think that we all need to really give each other permission to create the space, because IVF is not for the faint of heart. And sometimes, there is sort of this overshooting of like, oh my goodness, too much of a good thing. And it just takes a little bit longer to get back to baseline. And I think we all know that if we push through and we ignore those things, then sometimes it actually takes even longer to recover. So that's OHSS in a nutshell. I'd love to sort of answer more questions if you have them, but hopefully this helps to understand kind of what your REI is thinking and things that you can do in your own cycle to advocate for yourself and to start to feel better sooner. With that, I love you. I'll talk to you next time. Bye. Thank you for listening to the Love and Science podcast. I'm so glad you joined us today. If you found this conversation valuable, if you could please rate, review, and share this podcast with your trusted people, it would mean so much to me. If you want more tools to help you navigate the fertility journey, please book a discovery call with me today. The link is in the show notes. Please do not let infertility have the final word. I'm here to take the burden from you so that you can achieve your goal of building your family. In gratitude, this is Dr. Erica Bove. I'm rooting for you always.